I'm pleased to introduce the last scientific event of this Congress that I hope you enjoy. This will be the first orthodontic debate, friendly debate between one emerging technique and one consolidated technique in the invisible world. So one, the lingual technique, and the Invisalign technique. I just shortly summarizing the format of this scientific event. There will be a group of lingual defendants represented by Dr. Dirk Wigman from Germany, Massimo Valentini from Italy, Lorenzo Fabero from Italy, and Hitoshi Koyata from Japan. And from the Invisalign group, we'll have Bob Voigt from USA, Achille Farina from Italy, Werner Schupp from Germany, and Patrice Bergeron from France. There will be a panel of super parties represented by Mario Paz, USA, and Giuseppe Siciliani of Italy. And the chairman of this event will be Giovan Battista Garino, who is the chairman of the scientific committee of the ESO Council. The format will be that 5 questions will be given to the group. So the question is the same for each group. So each group will have 4 minutes to answer the same question given by the chairperson. And at the end, 2 minutes will be given to the audience if they want to make questions. Please place the audience the question to the attendees all in English, and the question can be made in the fixed place at the side of this room. So this will be the format by the 5 room for the 5 questions, and at the end will be the panel who will summarize and take the conclusion of this debate. So now I hope this will be a nice event. We will conclude this Congress. And now I will introduce you the Chairman of the Scientific Committee, Dr. Giovan Battista Garino. Thank you.
Thank you. We will start with the first question, which is type of movement more predictable with lingual technique or Invisalign, not recommended movement or less predictable, the anchorage with lingual technique or Invisalign. I suggest that the lingual group be the first answer.
If you ask me that more unpredictable movement in lingual orthodontics, and I answer, that should be a mandible, molar uprighting, and inside intrusion. Because that contributes to our vital opening. And if you ask me the less predictable movement in the lingual orthodontics, I may say as maxillary anterior, the torque and intrusion. I mean torque control and the intrusion of maxillary anterior teeth inside us. And if you ask me the anchorage in our lingual orthodontics, it should be a very strong anchorage in mandibular molars. That's the answer.
Thank you. Do you have some other Invisalign defender who would take the word on this topic?
But I think that the movement with the lingual technique are predictable, absolutely predictable. We don't have no recommended movement, in my opinion, or less predictable. And the anchorage is the same we can have with the labial technique. Sometimes maybe some different biomechanics at the lingual, but the doesn't affect the anchorage. And also with the lingual we can utilize some screws, some mini implants. So this is my question.
I think when I was doing my degree of dentistry at the university, almost 16 years ago. So I was a dental student and we had our first courses on orthodontics. We were taught that you can do tipping movements with removable appliances and you have a three-dimensional control with fixed. And I do not think that anything has changed in the last 16 years.
I think that in all this year we really demonstrate that with lingual orthodontics we can treat any case, also very, very difficult case. In these 15 years we demonstrated an increase in development of the technique. So what was one time forbidden, not allowed, now we can do. And also we understand better the advantages of these mechanics, the need for anchorage, and we are not afraid to treat any case. So I think it's not a real problem. So the question that the committee asked to our group, I think have not an answer, because we are allowed to treat any case. Of course, with specific knowledge, preparation, and training concerning lingual. But we are specialists, we are orthodontists, so we have to know. We are not a man taking from the role and doing orthodontist.
Thank you very much. The same question is for the defendant of Invisalign.
I'm very honored to be the first to open the debate for Invisalign and to answer at your question. I am not a fighter. I'm just a user of Invisalign, and I will give you the thinking of our community, of our colleagues. First of all, keep in mind that Invisalign is a new removable appliance. The more the liner is fitting, the more predictable movement would happen. The more tooth surface you have, the more predictable movement is. Second thing is that the movement depends if you use only the liner. It depends on the attachment you put on the teeth. It depends on the auxiliary you use, and it depends if you slow down the movement. The last thing is the learning curve. The more cases you're treated, the more predictable movement you have. Now, I want to give the answer for the beginner. We are seeking that the more predictable movement are tipping, incisor rotation less than 30 degrees, expansion, inclusion of the teeth one by one, and distalization with the class 2 elastic. The less predictable movement are the extrusion of the teeth, the torque, the translation, and the rotation with short and round corner. And the non-recommended movement is the mesialization of molar, the uprighting teeth, and the unerupted teeth. For the anchorage, when you are using an aesthetic removable appliance like Invisalign, is not like when you are using braces. The wires and the liner and the braces are the teeth. You don't put a wire in a slot, but you take each teeth with a clear aligner. So for more one teeth, you are the better anchorage. Because at the first stage in the clean shape, you can move only one teeth with the anchorage of all the other teeth. And after is like all the other technique. you can use the mini screw, and you can use the elastic. In conclusion of the first question, the more Invisalign patient, the more Invisalign practitioner, the more Invisalign study, the more Invisalign congress around the world, the more predictable movement you have. It's the same for all the new appliances, like lingual. Invisalign is more younger, so it seems less predictable. That the present of all the audience show that in the future, more and more movement will be predictable. Thank you.
Thank you very much. We have time now for discussion from assembly, which is some question. We have 2 minutes left. Please go.
The technique has been
Go on the microphone.
I can project.
It doesn't work.
The technique has been in existence for over 5 years and has been used by individuals who have understood and have designed the use of this appliance. I was able to see in some of the slides that were shown at the presentation, some were very good, but I was able to see that uprighting of the teeth, the tipping, and some of the teeth were not at the level that it should have been, even though it was claimed that they were uprighted. I mean, in some of the space closures, the cusps were still tipped back, the bicuspids were not uprighted as they should have been uprighted. As far as anchorage is concerned, I think it's the same. You know, you're really not anchoring on one unit, you're anchoring on the whole arch, and supposedly you're saying you're anchored, but we really need to see in detail the results, regardless of whether you do it with Invisalign or whether you do it with full complement of braces. You're anchoring one teeth against the mask. Believe me, they are going to move regardless whether you're anchoring them, you know, the appliance is anchoring itself on the other teeth. They will move as a response to the motor. The motors have much heavier roots, and it will bring the teeth back, or will cause a change, or will express a change to the other teeth. So I think that is a new point at this time, the anchorage issue.
We have time for one more question.
One of the things that Dr. Milson in Aarhus taught me was the concept of stationary anchorage. And we used to think with the Tweed technique, they would tip back bands, and if you tip the teeth back and so forth, they would have more anchorage. So we've had many wrong concepts, so to speak, about anchorage. I think Dr. Milson's idea of the teeth being stationary is very good because they're not undergoing a cellular process. So I would maintain that the anchorage is superior with Invisalign because you can cover the surfaces of the teeth without putting you can never make a wire completely passive, but you can definitely leave a tooth completely immobile with Invisalign. So I maintain that there is a very significant difference with Invisalign when it comes to anchorage because the anchorage can be completely stationary.
Thank you. We go for the second question. Go on, second question. The second question is, can we perform realistic objective due to aesthetic, occlusal, periodontal limits in adult and elderly orthodontic patients with Invisalign or with the lingual? The answer is for the defendant of Invisalign.
Okay, thank you. First of all, I would like to focus on the word realistic, which is very important when we're talking about Invisalign, because we received a clean check from the facility in Costa Rica, and it's up to us to identify what a realistic objective is. So it's not surprising for me to receive something which is very nice in the virtual world, but that is not going to happen in the real world. So and I like it because when I started learning Invisalign beginning of 2002, most of the people were thinking that even my assistant could do Invisalign because it was just sending impression to the US and receive those pieces of plastic back and put them into the patient mouth. And that's not Invisalign. The responsibility, it's up to us, and our knowledge is very important in identify the sequence of movements and the objective that are realistic with aligners. Very often, I make this example. I was with a friend like 3 years ago, and he's a technician, a dental technician, and he told me, "Oh, you're doing Invisalign." And I've seen in an office of your colleague this clean check, this movie, and it was quite surprising for me because I have seen that he was moving the second lower molar into the first molar place, closing the space with the aligners. Is it going to happen? Well, the guess was my answer. No, it's not going to happen. It's Invisalign, the piece of plastic that doesn't work. I don't think so. It's that we have to identify a realistic objective with aligners as we do with piece of plastic, same way. And in doing that, again, the clean check is something that is very useful in order to improve our way of doing a diagnosis. Because for the first time in my practice, I had a software that allowed me to superimpose the pre and post treatment result. I had a software that allows me to measure this movement and to decide if the amount of expansion that I'm thinking to achieve is too much, if the proclamation is too much, and if I want to do IPR, how much IPR I have to perform in this patient. So using the clean check and asking for different clean checks is going to improve your ability of really provide for your patient the best possible treatment modality. And that's something I really like, and I would like to use it not only in my Invisalign patient, but for all my patients.
Yeah, I think that's a very good point. And one of the things that I found with the residents, how much more time do we have?
Half minute.
Is that with the residents, we can get them to think about the treatment when we're discussing the treatment. And so it's a very good teaching tool. In fact, that was a lot of my initial interest. And so we have used it for indirect bonding and other procedures. And so we see a tremendous diagnostic value from the viewpoint of teaching. And so as a teacher for many years, I have found that that's an enormous positive thing because it makes me work harder to do a better job.
Thank you. What about lingual?
Well, I would like to be more close to the question and to answer to the question, because the question is concerning elderly, adultic, orthodontic patient, and concerning aesthetic, and so we can plan by computer and also by setup a perfect aesthetic of our case. The respect of occlusion is absolutely precise, and we can check before also. And concerning periodontal question, I think that lingual orthodontics is more close to normal, traditional orthodontics. We can use wire by technology that are very active, but they are also with continuous force, very light, very high memory. They don't interrupt the forces, the applied force in a different step. So, from a periodontal point of view, I think that lingual orthodontics is absolutely more close to biology. And another question concerning occlusion, we can interface the two, both artists, and to work together so we can get an occlusion with the two artists together and see what's happening and have the realistic situation of the moment. And also we can, modify, if we need the treatment, in individual situations, because what is predictable sometimes doesn't happen because of the patient, because of cooperation, because of biology of the bone, biology of periodontum, and so many things. Nothing is automatic. We know this.
So anyway, we can treat any case in a lingual, bilingual orthodontics. But I think the most tough case in the lingual orthodontics is a kind of gummy smile for me, because control of upper anterior teeth is most difficult.
Some question from our audience.
In the years of treatment with lingual braces and regular braces, periodontal problems have never been an issue. There's always been an improvement in the cases as I've treated them periodontically. As far as aesthetics, and I want to answer the point on the pain check and the diagnostic. Let me say that Dolphin Imaging and OrthoCAD as a system for doing your diagnosis will provide the same services as the pain check. And also let me say something, we're talking about Invisalign, but really there are other companies in the industry that offers the same type of services. We're talking about OrthoClear and also to some extent the aesthetic retainers. I think in essence here we're advertising to a company and we should really be looking at a system of clear treatment.
Right, now your question. Well, you forgot your question. You don't have to give an answer, you have to make a question.
Yes.
Okay, Fred, you are always welcome.
Yes. Question number 3. It is. Everything is great. Question number 3. It is quite different because it is for lingual defender. Case finishing with the lingual technique. Do you bend some final arch wire inspired of a straight wire system?
Yes, I bend some arch wire in spite of a straight wire system. Probably because the straight wire system is not so good, so accurate like I would like. But probably we have some. With the lingual orthodontics, we can program very well the second order band, the second order movement, and the third order movement by the staff. And I had some problems with the first order movement because of the correlation, arch-wire correlation, for example, because of the thickness of the in-out, and for that question. But at the end of treatment with the position of the first order bands, first order movement are very, very easy to be solved. And in my experience, the very hard movement are the second order and third order, and not the first order bands.
I think it's that you're treating with a straight wire system means sometimes you have to put manual bends in the wire, otherwise you have to compensate with resin under the bracket. But in the last 20 years, especially in the finishing in lingual orthodontics, I wouldn't say it's easy today, but it has become easier and easier. And all the techniques we have seen here, and a lot of the laboratory techniques, for example, the hero method, right from the beginning, is working with prefabricated wires which have already first order bands incorporated. So, the practitioner today doesn't have to make all the first order bands. In some techniques, even if it's ideal, he doesn't have to make any. Nevertheless, it's not a straight wire technique. So we have a lot of progress in the lingual movement because with the laboratory procedures getting better and better, and I think one of the most important in this step was the hero process. The amount of first order and third and second order bands have become less and less, and this will go on.
Thank you. That is a question for Invisalign. It sounds a little different. The case finishing with Invisalign, the treatment plane on 3D, the critical evaluation of a selected clean check, the refinement are at the end of the treatment, are on that direction.
Well, first off, we can't bend the aligner. So it's a completely different approach, and so we can't compare the two exactly, because I agree with you, everything you said, 100%. I mean, lingual is a highly evolved fixed appliance that came from our understanding of buccal movement and uses the wires, and it has tremendous advantages as a modification of a fixed appliance. Invisalign is totally different. I mean, it's not comparable at all. And of course, it's early in the development. If I took your cases from 1990, your lingual cases, if you were using it then, I tried it back then. They didn't, you know, we had problems finishing. So I think I commend this group. I have been misinformed about how far along lingual has become. You have truly perfected it. So I need to say that it's very important. Because you're all familiar with lingual, I had to learn this. So the point is, with Invisalign, you have to stand back and say, I have to get it, as Dr. Farina said, on the computer. And so things like, for example, overcorrection, I would have to say, well, given the limitations of this appliance, what do I have to do to the ClinCheck to make it finish better? So, for example, if you look at my deep bite cases, I finish them to an edge-to-edge occlusion on the computer, anticipating that I'm going to get maybe 2 millimeters of overbite. But we also bend a larger reverse curve in our arch wire. I mean, if the patient ever came back to your office, a year later when you put a wire like that, you'd have an open bite. So we do overcorrections all the time, and they're related, and so that's kind of thinking, but it's very different with Invisalign. So I think you have to look at the computer, and you have to imagine how that appliance, which is totally different than a fixed appliance, might affect. For me, that's very exciting because it's new. And so, but again, I tip my hat. It is amazing to me how you have perfected lingual. So I think getting back to my point, though, the finishing is you have to be able to look at the computer and anticipate things. And another point is that we go through the aligners and sometimes we don't quite get it. There was a comment today after my presentation that some of the lower incisors were not completely corrected in some of the pictures that I showed, which of course is pertinent to the finishing. And I realized, I went back and looked at that. Some of the pictures were taken from the case refinements. So I was ordering a few more aligners to do a little lower incisor correction. But it's interesting how that's the difference in focus. See, your group is down to what I call the nitty-gritty. You're down to the absolute details of finishing, and you have a precise instrument to do it. I have to have much more imagination and creativity because nobody is showing me the way. So you're showing all of the people here how to do this, and that's fantastic. And I'm trying to do my best, but I'm a pioneer. I'm not at that level of perfection. I hope someday that I can be. So I think it's very important that we understand that it's a completely different approach. And so in finishing, we take a new impression, take some new photographs, and then we order a few more aligners. And so the finishing is really something that you try and get in the beginning, and then at the end, if you didn't quite get it, then you would take a new impression and order some more aligners to achieve the things like the little incisor corrections that you might do, for instance, with a spring retainer if you did it with fixed, maybe. So I think that was an important point. How much more time do I have? I want to be sure to use it all up because Dr. Marconi is only going to stand up and take it. Give us another speech. So, I think, how much time?
Half a minute.
Half a minute. Oh, I wanted to say a little bit more about the overcorrections. We used to overcorrect incisors, but that was a failure of the technique because we didn't understand how to complete rotations. We do overcorrect, overbite corrections. We overcorrect. My arches look very expanded on the computer because I only get maybe 70% of the expansion. So again, it's a very different sort of a technique. Not better, not worse, different.
Thank you. Is there some question from our audience?
You showed a very interesting situation. This is an experience that I've had when using SX retainers, in which you open the bite, but you left the retainers on as a retainer in a closed bite case. My experience has been with aligners of any kind, even the Essex retainer, that if I had a deep bite case and I leave an aligner in there in a deep bite case, what I end up doing is actually closing the bite. It is similar to what we used to do when, we used splits. You put a splint in a posterior segment, you're going to deepen the bite. So, it was interesting that you made that statement, it's leaving an aligner. Usually what I do now is I leave a 3 to 3 and let the posteriors disapprove.
Well, thank you very much.
That was a question.
Does it sound like a statement? No, I agree with you. I think I'm only having the patient wear the aligners at night when they sleep, 6-8 hours if they're lucky, and sometimes they don't wear them. So the teeth tend to, just like with an Essex retainer, I learned that with Essex retainers, when they go to nighttime, when they're wearing them full time, the bite will open in the back, and when they go to nighttime. So I think that's a temporary problem.
Right. Thank you. We go to question number 4.
Sylvia from Vienna. I think one of the best things to working with lingual orthodontics is the 3-dimensional setup to visualize our treatment goal. And it's a very good method to visualize and to see Bolton discrepancies and so on, and to see if we can reach our goals and the 6 keys of interest, perhaps. I have a question to Mr. Boyd. Do you think on a computer it's 2-dimensional, that we can make the same planning as we have a plaster model 3-dimensional, which we can see from each side? I think it's very hard for me. I make lingual orthodontics, I'm making Invisalign, but the planning phase, if the planning was 3-dimensional or 2-dimensional, do you think it's possible the same as the 3-dimensional?
That's a very good question, and I was very ignorant for a long time, and I didn't understand that. A computer does something called rendering. It is a 2-dimensional object that has shadowing and characteristics. But the point is, the computer has a picture in its mind of the actual 3-dimensional. So all you're looking at on the computer is a representation with a 2-dimensional. That's why to see 3-dimensional, you have to wear special glasses or have other techniques to show it. So when we look at a computer monitor, it's flat plane, and it only shows what appears to be 3-dimensional. So the idea is it must be accurate, and so we do have the internal. If we make a stereolithographic model of that computer stage, then we have the actual 3-dimensional model. So thank you for making that point. That's something that I operated out of ignorance for many years, not understanding that.
Thank you. We go to question number 4, which is, can we use Invisalign or lingual technique as a phase 2 treatment of malocclusion permanent dentition after a functional orthopedic phase 1 in mixed dentition? The question is for Invisalign people first.
Thank you. I strongly believe that we have, as orthodontists and orthopedics, the duty to treat the children with class 2 and class 3 with orthopedic concepts, and not in the beginning with orthodontic concepts. I think we can create faces and we can create harmonious faces if we use functional appliances. I strongly believe in this. I strongly believe that in class 2 cases, in a lot of class 2 cases, it is not a fault in the upper jaw, it's a fault in the lower jaw. And I also believe, and there are good research from Frankel and many other people, Petrovich, that we can, if we use functional appliances, we can create a harmonious TMG situation after the treatment. But I also strongly believe that after functional appliances, we definitely have to use orthodontic concepts. We have to use fixed appliance, or now we can use Invisalign appliance. And I would like that you understand that this is my message. And let the patient decide what to use. But we have to create a gnatologic occlusion after the functional appliance. And after the functional appliance, we have not a severe situation for the therapy, for the orthodontic therapy. So in most of these cases, we can use the Invisalign appliance to finish the case in a perfect way. And what is the fault if I have to upright a tooth and I use the sectional mechanics for a few weeks? It's not only for the phase 2 after the functional appliance. For me, I can treat, or we here, we can treat every case with Invisalign. But sure, definitely, in some cases, for a few weeks, maybe for a few months, we have to use sectional fixed appliances, buccally or lingually. But what is the problem to change the mechanics? It is our thing, we are orthodontists and we can decide what can we do for the patient. And the patient can decide what he likes. Does he like metal braces in the front? Does he like lingual appliance? Does he like Invisalign? I think the case selection. The case selection is the main important thing. To see with the experience we have, can I start this case with Invisalign, or do I need sectional mechanics first? And then I can explain this to the patient, and then I have a perfect result in all these cases. And for me, especially in the young children, I treat first with functional appliance, then with Invisalign. I know if they cooperate or not, because I treated all these patients with a functional appliance before. If they do not cooperate with the Frankel appliance, they do not cooperate with Invisalign. Unbelievable to believe that if I change to Invisalign, that the child will use the Invisalign appliance. No, this is not an Invisalign case. Case selection is the main important thing, also in these cases. But for me, and I think we agree, we know all the studies that we have invasive techniques. And now, and in the last 16 years, all over the world, we have a lot of changes. In the medicine, we have a lot of changes, and also in orthodontics, we have a lot of changes. And the main global trend in the medicine, all over the world, is the less invasive therapy. And with Invisalign, we have a less invasive appliance, and especially in the young patients. After functional appliance, for me, the less invasive therapy with Invisalign is the best we can do for this patient. Thank you very much. For the lingual system?
Yes, of course, we can use lingual appliance as a phase 2 treatment. But I don't understand exactly the question, because it's the natural evolution. After functional appliance or orthopedic treatment, so the early treatment, interceptive treatment, we do 2-phase treatment to resolve and to use by our best result growth, to use growth. But when we need to have the second phase treatment is because the first treatment was not able to resolve anything, the complete case. So the second phase, we use mostly teeth. We need to be very precise. We need to give the answer to the competition of the tissue that can be very bad. In many cases, we have to manage extraction case, difficult case. And you say that you are not able to do that. So why to manage cases with alpha treatment in one way, and then again set up and going to lingual again? Why this? Why not only a well-programmed lingual case, very precise with the correct anchorage, precise movement of the teeth, and complete resolution from an occlusal and aesthetic point of view? Why come back to a very simple orthodontic, but easy managing, but not so precise and concluding to the goal, the final goal of the patient? Thank you.
I think Werner said that, and I appreciate a lot, because I think you're at least partly right, because you said the tendency in medicine is to be less and less invasive. But I think you have completely forgotten the other side of the story. Because the first goal is always to have a perfect result. So when you can have a perfect result, then you can think about minimizing your treatment objectives. But you're minimizing your treatment objectives, and you're also minimizing the quality of your result. And this, I think, is not the trend in medicine.
Thank you. I would like to comment at this moment, because I confess that I use both methods, lingual technique and Invisalign. And I would like to express my opinion, personal opinion, the opinion of Massimo